call. But in the meantime, for those of you that are here, if you could please in the chat put your name, title, and agency that you represent, and let us know if you're here on behalf of IHSS, APS, like what's your role there at the county. That would be great too. And then, because we're not going to do formal introductions, you'll be amazed at how fast the 90 minutes come and go. And so we're going to get right into the content after we do some quick introductions. All right, I see our Anthem presenters are all here. Eric just joined us. Again, afternoon. Thank you for being here with us. This is a CWDA CFPIC hosted meet and greet with our partners from Anthem Managed Care Plan. They're here to talk to us about all the services that they provide. In addition to those that are new and part of the CalAIM initiative. And I'm going to hand it over to Andrea to introduce herself and welcome you all.
Yeah, thank you, Belgi. Good afternoon. I'm Andrea Sobrato with CFPIC, and we're thrilled to host this kind of meet and greet today with Anthem and our IHSS adults folks here on the call. We'll drop the PowerPoint into the chat in just a minute. And I just want to say the purpose of today is really to give you all an opportunity to get to know Anthem, to understand who to contact, who does what in Anthem. So you have contact information and you understand a little bit more about the services that Anthem provides your members and how you can engage in CalAIM. And even consider if anybody on the call is considering becoming an ECM provider, like what that might look like and what support there is for you. As Anthem is presenting, please feel free to drop your questions into chat. We will field those to the Anthem presenters as they're moving through their PowerPoint, and especially those questions that are kind of on topic with what they're talking about. We will just get those on deck in real time. And the rest of the questions that we don't get to, we will save about 30 minutes towards the end of this afternoon to work through those questions. We will also record this. As you know, you're being recorded. We'll post this, the recording of this, we'll post the PowerPoint. We'll actually post a written version of the Q&A that happens today on the call as well. So you'll have lots of resources on the CFPIC website following this call. So with that, I will turn it on over to the Anthem folks to introduce yourselves and take it away.
Janet, Selena, or Eric, whoever wants to start first.
Are we doing introductions or are we just getting started?
No, sorry.
Okay.
It was on mute. I was just talking away while I was trying to share my screen. So no, thanks, Selena. So thank you for the introduction and thank you for having us here today. So I am Janet Payne. I'm the director of Anthem's County Account Management team. It's good to see some familiar names out there. We've got our County Account Management Program managers on the call also, and then we've got our special programs team on the call also. So Selena Escobar, who's our director of special programs, and then Eric Schwiver, who's going to present. But I wanted to just give you an overview of Anthem Blue Cross Medi-Cal Managed Care Plan in California. We are also known as Blue Cross of California Partnership Plan. So you will see that on any legal documents, MOUs that we may execute with the county agencies. That is our legal name in California. Although we do go by Anthem, you'll see us go by Anthem Blue Cross. Just like to clarify that, a lot of people want to know if we are Blue Cross Blue Shield, and I always say no, because Blue Shield in California is our competitor. So we are Blue Cross Blue Shield in other states, but not California. So just like to throw that out there and then put both of our names on any of the materials that we're sharing also. So we have been the Medi-Cal Managed Care Plan in California since 1994. Currently, we've got 1.3 million lives covered by our Medi-Cal Managed Care Plan, covering 16 counties in California. And you can see our network access here in terms of number of contracted primary care providers, specialists, safety net providers, which include FQHCs, rural health clinics, Indian health centers, and then we have the CVAS centers and the LTCs. Some of the newer populations and benefits that entered into the Medi-Cal managed care plans starting January 2024 were the dually eligible special needs plans, the intermediate care facilities, and developmentally disabled. Justice involved, we're starting to get actively involved in that. Undocumented immigrants, ages 26 to 49, and then added services to cover dyadic care, community health workers, doula benefit, and street medicine. So that is a little bit of a background of who Anthem is as far as the Medi-Cal managed care plan. We do provide and cover all of the 10 essential benefits that DHCS requires a health plan to cover, which includes primary care, hospital, pharmacy, lab, specialty visits, etc. And then in addition to that, we do like to offer some additional benefits where we're looking at the whole person. So really understanding that healthcare is not just about a doctor visit or a hospital visit, but it's also about all of those other wraparound services that really support the members' well-being and tie to their positive health outcomes. So you can see here a number of the additional services that we do offer. Expanded telehealth options, which includes Live Health Online, which is an urgent care, 24/7 urgent care option. It also includes behavioral health and then maternal mental health options. We have Sydney Health, which is a mobile app where members can actually go out and access any of their benefit information that they want to know about. We connect our members to essential resources. That's where Selena's team comes into play with housing and food insecurity issues, looking at job resources, education, legal aid. So really looking at those support services that members need to access that will lead them to their positive health outcomes also. Doula services are provided. We do provide transportation to doctor's appointments and some non-medical trips. We've got a 24-hour nurse line service, interpreters and translation services, health education classes. We have a program that supports our members, our new moms and our new babies called New Baby, New Life. And then we've got a robust care management, case management program also, and services, and a team. And then in addition to that, we also have the special programs team, which includes CalAIM and the ECM and the CS services. So that is a quick overview of Anthem in general. And from here, I will turn it over to Eric or Selena to talk about CalAIM and special programs.
Hey, this is Eric. I'm happy to speak on this. Selena, do you want to go first?
I sure can. Hi, everyone. Thank you, Janet. And then Eric, I'll hand off to you when we get to ECM. So a quick overview here. You all may or may not be familiar with CalAIM, California Advancing and Innovating Medi-Cal. I think it's a really awesome program, just a package of services that complement one another, also support our members, and really enhancing our whole person care. So I'll just kind of go through this circle here. Our network development. So statewide, we are looking for community-based organizations, local organizations that have established relationships with our members, that have been providing services like enhanced care management and community supports, and we'll talk through those in a bit, and ensuring we can connect with them so that they can continue to serve our members. Workforce recruitment. So we have incentive funds to be able to work with our network providers, our CalAIM providers, and help them to build and strengthen their workforce if needed. Some of them add on community health workers, and I think we'll touch on that in just a bit as well. But our enhanced care management, lead care managers, our community supports, housing navigators. Some of these providers are really interested in growing and expanding. And so, there are opportunities for them as we build relationships to be able to do that. Definitely community engagement. Again, really focusing on the local community-based organizations, schools, just those organizations overall that have those relationships and service coordination. So Eric will go into a little bit more detail on, again, how we can connect our members to the enhanced care management services where they fit best, and then add on community supports as well to help really strengthen the services and the access that they need. So I think we can go on to the next slide. And I did share a little bit of, oh, go ahead, Eric. Do you want to, take that?
Yeah, just kind of adding on to what you were saying about CalAIM. By the way, I don't think I didn't get an opportunity to introduce myself. I'm experiencing some instability in my network, I'm being told. So I'm leaving my camera off for now, hoping that helps with my voice at least. But yeah, so CalAIM is it provides all the context here. Huge, as you're probably mostly aware, right? I know IHSS is a Medi-Cal program, so you're probably fully up to speed on this stuff. But big reform proposal for Medi-Cal, structural changes, affects managed care plans, affects counties, payment reform. And I think what's most exciting about the CalAIM vision is that it enables this cross-sector vision, because we know that our members, and I have a slide on this a little bit later, we know that our members they participate, or they receive services from multiple delivery systems, and those delivery systems don't talk to each other very well. And ECM, that I'm going to spend most of the time on, is a strategy for bridging, for bridging those silos and providing the best sort of person-centered, holistic care that we can to our members. So we're all very excited about it here at Anthem. And the aims here, of course, are moving us as a healthcare system and social support system, as a safe net, right? Moving us towards a more equitable system and improving outcomes. So I think that's what's important about CalAIM, to me at least. Next slide, please. All right, so now getting into to enhanced care management. So enhanced care management, you can tell by just what I was saying, is a holistic approach. It is really, and we'll talk about this a little bit more on a different slide, but it is an ECM provider isn't necessarily an expert in behavioral health, or an expert in developmental disabilities, or in activities of daily living, right? There's subject matter experts for all those fields. The idea of enhanced care management is it's one person who's kind of like a point of contact for all those different needs. And I like to think of as like a project manager. I think DHCS uses the term like air traffic controller. But ECM isn't meant to replace any existing services. It's meant to complement them. With some exceptions, there are some areas where DHCS says there could be duplication here. And then I'll just highlight here, ECM is really is kind of at the top of the pyramid in terms of like acuity of members that we're looking at, starting with, sort of the base. All of our members have access to some basic care coordination. And then our highest risk, sort of highest medical risk members have access to telephonic managed care plan, supplied case management, that gets them through an acute hospital stay, for example. And then we have enhanced care management, which is intended for the top 1 to 3% of our members in terms of acuity and risk. And those are the folks, Janet shared that we have about 1.3 million members. So, more than 1.13,000 members should be eligible for this program statewide. And we're excited about our conversation with you today, because hopefully you can help us find those members and get them enrolled in this program, because we know they're out there, but our referral networks are not as strong as they need to be. 7 core services with enhanced care management. That's what we're paying for. The first is outreach and engagement, and this is ideally where the enhanced care management provider is leveraging their base and building relationships with potential referral partners and engaging members and sending us their referrals. That's the idea here. And that's actually, you know, a lot of programs, that's not a service that's paid for, right? It's kind of assumed that that just happens. But DHCS in its wisdom, and something we advocated for, actually pays for that service, because it's super important. That's the front door to receiving these services. Then there's assessment and care planning. So this is where the care manager identifies the member's needs and helps the member articulate their goals. You know, it should be a conversation, and the member should own those goals. Those goals should cover both clinical and non-clinical, or that assessment should reflect both clinical and non-clinical needs. And for a lot of the members, you know, complex folks are touching multiple systems of care, right? Physical, behavioral health, long-term services and supports, oral health like dentists, social supports, et cetera. All those things should be reflected in one single, you know, unified care plan. And next core service is enhanced coordination of care, which is essentially implementing the care plan, connecting to the PCP, the primary care physician, developing the care team, engaging those different care team members, including friends and family, right? Those natural supports. And I can see that's kind of a tie into IHSS, aligning informal supports, you know, that might exist out there, communicating and advocating for the members' needs and their goals. You know, and basically, you know, supporting the member through their treatment, you know, whatever they need to get it done. You know, that might mean making appointments, maybe attending appointments, checking on medication adherence if there's chronic conditions that are involved, that are, you know, the member's needs, arranging transportation, those kinds of things. The next core service is health promotion. And this is where, you know, the lead care manager is working with the member and their natural supports, their family, they're working with their social supports, they're providing coaching, which is where one of our community supports, I have a slide on this later, but we have a rehabilitation community support that can supplement work here, you know, life coaching, linking those members to community resources, health plan resources that might be available in another system of care. Then there's very important one here, transitional care services. And this is where the lead care manager is tracking the admits and discharges, right? Tracking that member if they're hospitalized, because we know that transition from hospitalization can be, you know, that's a critical moment, a very sensitive moment. A lot of things can go wrong, you know, in that transition if we're not on top of things. So that's a moment when they're, you know, extra attentive and spending a lot more time, you know, with the member and the care team, making sure that none of the needs falls through the cracks. The next thing here is member and family supports, and this is, you know, again, re-emphasizing that need for you know, including the family, including those natural supports in the care team, supporting them. With, you know, we also have community supports for that. So we have respite care, for example, that we'll talk about in a little bit. Respite care is basically gives the you know, often a family member who's taking care of the member, kind of like in the IHSS context, a break. You know, gives them 24 hours or gives them a few days to do something else other than take care of their loved one. So then there's the last one here is community supports coordination. And that's where, you know, you've got identified in your assessment, there's these unmet social needs. You're making referrals out to the community. You're checking to make sure that you know, not only that referral has been made, but that the member is actually receiving services. So you're closing the loop. I think that's what I want to emphasize there. You know, that's make sure that we're emphasizing those social needs along with the medical needs. All right, next slide, please, Janet. So there are, you can get rid of the, thank you. Yeah, we don't need the notes in there. So these are the populations of focus, and there's 10 of them. Each one has an adult equivalent and a child and youth equivalent. So on the adult side, we've got, adults, independent, sort of adults experiencing homelessness with children or without children. We have individuals at risk of avoidable hospitalizations. That's a very popular one. Individuals with serious mental illness or SUD. That's another popular one. Transitioning from incarceration is a new one for us, something that we're currently developing and are very excited about. And then two that are specific to adults, and maybe specific to this, to all you as well. I mean, these adults living in the community and at risk for long-term care, institutionalization, really key one. We need to work on a referral base for this one, but we're working with a lot of providers out there that have tons of experience in this area with money follows the person. I know you can think of IHSS as being a diversion program as well, and we're trying to connect. We would love to be able to connect with IHSS departments, in our counties, and with those caregivers to help support members in this population of focus. Number 6 is adult nursing facility residents transitioning to the community. These are folks who are in a long-term care facility and with the right supports could live independently. And so it's a question, combining the resources of enhanced care management, combining the resources with community supports. Is that enough for that member to live in the community with those supports? And if the answer is yes, then they qualify for those services. The very last one with an adult focus is the birth equity population of focus. And that is basically an adult who is pregnant and meets certain race criteria, which I believe is to be Black, American, Indian, Alaska Native, or Pacific Islander. All right, next slide, please. Actually, one more slide. This is the child youth version. Okay, so to me, this is like the most important slide in the deck. I mean, this is why ECM, this is the value proposition for ECM is, and I think I mentioned a couple of these things already. I mean, any one of your members, any one of our members could be touching on multiple systems of care at the same time, and they don't necessarily talk to each other, or they don't talk to each other very well. And so the ECM provider is one strategy, and I'd love to, there are other strategies, right, that we could pursue, like data exchange as well. But ECM providers is one way of getting those silos to connect with each other, to be a little bit more integrated and provide a little bit more holistic care to the member. And so the ECM provider in this case is the single point of contact across multiple programs. As long as everyone buys into that concept, then it can work. The ECM provider could go to a Department of Social Services social worker, and if that social worker is expecting them, then there can be a real collaboration there, right? Not a we're not doing, even though we've got a program that sounds like IHSS, we're not replacing IHSS. We are specifically and mandated by the state to sort of complement. We provide personal care attendant services to our members only as long as it doesn't interfere with their IHSS or during the period when that assessment's happening, until that IHSS delivery is actually started to take place. We might provide it there, or on top of their 283 hours, or if they've got the maximum hours and they could use just a few more, we might provide that personal care attendant services in that case. But it complements, it does not replace, and that's really key. And one last point here, the ideal kind of integration is that the county social services, you could be you could be ECM providers too. So you've got the benefit, the expertise in what you're already doing, and then on top of that, you could add in a bit more scope, right? Maybe connecting with other systems of care to your scope and get paid for ECM as well. All right, next slide, please. And feel free, in our morning session, people add questions, and then we went through some questions as we were doing it. I much prefer that. So if there are questions that come up, please highlight those for me, and I'd be happy to try to address them. All right, here's some numbers. This is what it looks at. We've got here on the left side a grid with the number of our adult members who are enrolled by different adult populations of focus and the number of providers that are serving them. And then on the right side, we have all of the Anthem counties, 16 counties, with the number of adult, whoops, I'm sorry, I didn't change this. This is adult population of focus providers, not child welfare population of focus providers. Copy and paste error. I think what this really highlights here is kind of where our challenges are. I mean, you can see, we've got our most popular one with, like 4,200 people enrolled is our SMI SUD population of focus. And that reflects, terrific collaboration we've had with behavioral health departments for a while. And also, the availability of data, right? But in homelessness, the same thing. We've got this great new data sharing collaboration with the homeless management information system. So we know, that's not 100% list of who's homeless, but it's the best. It's better than anything we've ever had as a managed care plan to know who our members are, who are experiencing homelessness, and we're able to be proactive about that and get those members ECM services, and that's reflected in the numbers here. Preventable hospitalizations, I mean, that's the health plans bread and butter, so those numbers are high. We've always worked with those members, and so we're experts in that area, and we've got great data to support it. But look at birth equity. We don't have the relationships there to support referrals. So our number of referrals are really low. Nursing facility transition, you could argue that there are fewer members who are eligible, but we're trying to expand that and expand our referral base by working with CBAS centers. We'd love to be working with county departments of social services as well, and see if we can, improve our ability to make referrals into this population, identify those members. That's what I'll highlight there. And I'm happy to answer any questions about any of those populations of focus.
So we do have one question in the chat, Eric. What is the baseline number of encounters, visits for a care coordinator in ECM?
Can you rephrase that? The baseline number of encounters?
Yeah, actually, it's coming from Peter with CFPIC, so I'm going to let Peter share his question.
Okay, thank you. Yes, so my question was more specifically for individuals who are enrolled in ECM. I understand they're because I have experience working in the Health Homes program. Is there I understand it will probably vary based on the member's health needs, but in ECM, what is the minimum amount of encounters that care coordinator will reach out to the member population?
Oh, sure. Well, first of all, I'm glad you mentioned Health Homes. That was my program before. I run that program for Anthem before CalAIM started. Really great kind of learnings from Health Homes led to and whole person care at the same time. It's a care coordination program specifically focused on high utilizers. So we have the same, at least, there's different health plans had different models for this, but Anthem's model is the same for Health Homes as it is for ECM. We require just one, in order to get paid the per member per month rate. And I have a slide on this a little bit later, but that's how a month of care coordination is paid. We require one visit face-to-face with that member. It doesn't have to be necessarily face-to-face, but you have to have a member visit in that month. Sorry, I know I wasn't very articulate about that, but we'd expect with some populations of focus, and depending on the time and the timing of the needs that the member has, we'd expect, there could be several visits in a month. It really depends. Like during the transition care services period, that's a time of intense need. Now we would expect to have, multiple visits in a particular month, but we don't require that for the purpose of billing. We require just one visit with a member. And there may be a lot of other, kind of care coordination activities that happen when the member isn't present. And that is, there are different rules for billing for those.
Thank you. And just a quick follow-up to that. So I assume if there's some sort of health action plan tied to that, would that be shared with the county departments? Is there some sort of coordination on that end?
We have all of our members are assessed, and all of our members have care plans. And currently, those care plans are shared through our portal with the care team that has access to our portal. When we're talking about social services departments, that's definitely something we can discuss. And I think there could be some value in sharing those care plans with other stakeholders. We'd have to just figure out how to deliver those and some of the legal issues around that.
Perfect. Thank you.
All right. Next slide, please. All right, so we have a no wrong door to referrals. So if you have someone that you're working with that you think might be eligible for one of our populations of focus, and you aren't particularly familiar with what those populations of focus are and what the criteria are, you can call customer care. And customer care, you just mentioned ECM, and you say you think that your member, like your client might be eligible for it, or the client themselves can call and say, I'm interested in in ECM and I'm experiencing homelessness. That member will be moved to into a triage process, and then that will eventually result in a referral that comes to my team, and they'll make sure that member meets the eligibility criteria, and then assign that member to a provider. So that's the route you take when you're not familiar with the criteria. If you are familiar with the criteria, you can send a referral form directly to our ECM team, and that kind of shortcuts the referral process, and you get a quicker response. Another way to do it is to talk to your local ECM provider. So all that data, list of our providers is on our website in our provider directory. You can find the local ECM. You think your member is experiencing homelessness, or is at risk of like a lot of IHSS members receiving IHSS services might be at risk of institutionalization. You can call the ECM provider that's certified for that population of focus, and again, that's in our provider directory, and say, hey, I've got this person. You can describe their needs, and they can advise you on whether or not they meet criteria, and they can make a referral on your behalf. So that's another pathway into it. All right, next slide, please. Okay, so a little bit of background on community supports. So I'm going to break this down a little bit differently than it's shown here, but all 14 community supports are listed here. I'll mention real quick that they are not benefits. They're not required for managed care plans to provide at this time, but we believe that they will be, and we're certainly treating them that way, and we've embraced all 14 community supports, and we're providing them statewide. So I kind of think about them in four buckets. One bucket is for to support people who need housing, particularly those experiencing homelessness. And there's three. There's housing navigation, to find housing deposits, to pay for that housing tenancy, and support services to keep that person in housing should there be some challenges with that. There's dehabilitation to support, to build some life skills, and that can also be important to working with landlords or maintenance people, or other stakeholders in that housing environment. Short-term post-hospitalization. This is I think of, and I could be a little off on this. Selena, please please correct me if you need to, but this is like a sort of a staging ground. A member is released from the hospital, is fairly stable, but doesn't have housing, and they can basically stay for up to 6 months over the lifetime of the the benefit. They can stay up for 6 months in a short-term housing situation where they can kind of get set up for that next stage of looking for housing. And then that's complemented by something. Oh, go ahead, Selena.
Sorry. It is short term, and often recuperative care is the first sort of step after a discharge from a hospital or a facility. And so for those individuals that need a place to recover, and their living environment, or if it's a homeless encampment, is probably not ideal environment for them to recover. So often recuperative care, and then short-term post-hospitalization housing. And Eric, I think you mentioned, that's a really good opportunity for those individuals that are experiencing homelessness to get connected with the housing navigator to assist them in finding that more permanent supportive housing. So I'll let you go on. Just wanted to add
Thank
that.
you. Thank you. So that's the first bucket. That's, for individuals experiencing homelessness. Second bucket is those supports that can help keep people at home. And this, I think, is really, appropriate to this audience. We're talking about respite care. I mentioned it earlier, which is like, support or relief for the, generally, family caregiver, take a day, take a week off, and do something else. And while you know that your loved one is being supported. There's also personal care and homemaker services. I mentioned this one as well. And this is contingent. This is, has to be coordinated with IHSS to make sure that it's not interfering or replacing IHSS services.
And if I could add to that one, and we also have our community supports director on the call too. So Katie, if I miss anything, throw a virtual tomato at me. But so I want to stop here on our personal care homemaker services. As Eric mentioned, one of the criteria that will help our members to be eligible is if a member is on a waiting list for IHSS services, they are eligible for personal care homemaker services, which are very much like IHSS services. The other way that they are eligible for personal care is if they have maxed out on their IHSS hours as well. And, so I'll ask Katie if I missed anything there, but I'd love to, and our team would love to connect with you all even after this meeting and kind of go into a little bit more detail on how we can coordinate and share data and reports, and just I think build a good relationship.
Thanks, Selena.
Thank you.
And Katie, feel free to speak up here. Couple more services that help keep our folks at home and reduce the risk of institutionalization. Environmental accessibility. This is grab bars. This is ramps. This is door widening. Maybe an air conditioner. Right, things that are going to make it possible for that person to live at home. Sort of physical changes to the housing. There's also nursing facility transition and community transition services. So 2 more community supports that are specifically focused on those kind of logistics and supports that are needed to get that member from a nursing facility to a community setting, or to maintain that member safely in that community setting. So that's the second bucket, right? So 2 buckets: 1, experiencing homelessness; 2, once they've got housing, how do you keep them stable, especially for aging adults? 3, third bucket is support for managing a chronic condition. And there's a couple of them here that fall into that category. There's meals, medically tailored meals. And I think, that probably speaks for itself, but lots of chronic conditions are sensitive to nutrition, of course. And then asthma remediation. And then there's one more bucket that kind of sits alone, which is support, which is our sobering centers. So, if someone is picked up by law enforcement or by fire department, and they're intoxicated, they can be brought to this place where they can sober up. And this is a diversion from jail or from ER. So those are all the community supports that we offer.
Can I'm going to give an opportunity for anyone from the county to ask a question about community supports, but I do have a couple of questions myself. So if anyone does have a question around community supports, if you want to raise your hand. All right, don't see it. So I'm going to ask, I have a couple of questions that I've been stewing on for a little while to better understand how to utilize these supports. So around the housing and homeless community supports, especially around like the short-term post-hospitalization and the medical respite, when I look at the policy guide that DHCS put out, they seem to be time limited. Knowing that we are in a pretty significant housing crisis where we don't have enough available or affordable housing, and moving folks on to more stable housing is going to be an issue, especially in certain counties. Is that time limit flexible, or are there limits to that?
I'm not the best person to address those questions, but if we do have Katie on the call, perhaps she can, or Selena. And we could definitely
I'm
get back
happy
to you,
to-
Baljeet.
Can you guys
Go
hear me
ahead.
okay? This is Katie.
Yep.
Hi, everyone. I'm the program director for community supports. Thank you. Great question. Yes, and this has been a question I think a lot of providers have had. You know, we know that, you know, housing is at a premium. I think what Anthem can offer is that we have a very sort of elite team of our housing strategy team that supports all our efforts in standing up ECM and CS, working with the COCs, you know, supporting data exchange and data exchange with HMIS. And I think that through HIP, it's been just incredible, some of the solutions that not just our plan, but I think all of the plans have really come upon to increase the number of beds, increase the locations for permanent housing and other housing solutions. So hopefully that landscape is shifting, I think in part due to CalAIM. I think it really depends on the county, but definitely recognize that that is a challenge. So for recuperative care, it's 90 days. You know, I think it just depends on the situation with the member. I think it could be member specific if there's needs beyond that. And if there's needs beyond that, we might need to engage a higher level of care. I mean, that could be ensuring that they're enrolled in ECM, making sure they're connected with the COC and the coordinated entry system. And then for short-term post-hospitalization, it's similar. I will tell you also, the providers for these services, a really strong partner has become our shelters, because they're doing this work already, because the facilities don't already exist as freestanding facilities. So we've worked a lot with shelters to be able to manage, you know, members that might have these needs and get the right staff on board. So hopefully that, I know, helps sort of answer that question.
Yeah, it does. Thank you so much. And then some of these community supports come with a dollar amount, right? Like a dollar maximum. And one of the questions that I have always wondered about, especially in homes where you have more than one member, is it per member, the dollar amount, or per household?
It is per member. So it's based on member eligibility and enrollment in Anthem as their health plan. So when you're looking at something like asthma or home modifications, the asthma remediation is up to $7,500. Often, you know, sometimes these are children, sometimes they're remediations for rentals. We haven't gotten really high value requests for that. So, which is great in case somebody moves and needs to utilize the service again. And for housing deposits, you know, we've been able to have a pretty great utilization of housing deposits, I would say, given the limit. And I think often that would benefit a household, right? And then for, what's the other one I'm forgetting? I think those are the housing deposits and then the home modifications. Home modifications is challenging. One of the pieces for our home mods providers, I think it's key to be connected in with the AAAs, you know, to offset some of the costs, like for higher value modification needs, such as ramps or even electric chairlift. Those are well above 7,500. So we're always looking for partnerships within a community to make sure that there's other streams of funding that we can braid to support our members' needs, even if the request is above the amount.
Great. And last question, we talked about respite services this morning and how they apply to the foster youth population, for the adult and aging population and our IHSS population. Can you kind of walk us through respite services for that population? Like, do they select the provider, the recipient themselves, or is it a list of providers that you have for this? Kind of, what would that look like?
Yeah, I think it depends on the provider and the model that they that they provide. So one plug I want to say is, if you have providers and you think they should be part of personal care and homemaker services, please let us know. It has a pretty low utilization. We do have some providers where you do have the ability to choose, and the caregiver friend, and they will train them to be, which although has a bit of a turnaround time, but they will train them to be your the member's respite provider, which can be challenging if they need a break. And then also, in addition, you can, but the provider will identify. We've tried to make, I think, a concerted effort to ensure that we are bringing on providers who have staff that they can then identify to be the caregiver that comes in. And so that typically, you know, I don't have too many sort of use cases where that to sort of draw from, because the utilization is pretty low. But I imagine if someone is brought in that doesn't, you know, a person may not feel, you know, is appropriate, the member can ask for another caregiver.
Great. Thank you so much.
Yeah, no problem. Thank you. Any other questions? I guess my question was if there was anyone who has tried to submit a referral for any members, and maybe what that experience was like. And if you had success, because I recognize a few names on here that I've presented to in the past about services. So. Okay.
Well, I can,
to everybody else. Okay.
Yeah, I can share that from the morning session, we submitted, you know, we had the participants complete a survey. And one of the questions was, when you do submit a referral, what is the expectation about the feedback loop when you do submit a referral?
Yeah.
On community supports or
Yep.
ECM?
Sure, I can share. For community sports, you'll get a confirmation that it's been received and assigned. If you're a contracted provider, you know, our best practice is that we will send you the authorization information. You can also access this. You'll receive it by letter. The member will receive it by letter. That you can also access it in P360, as well as Availity for our contracted providers, as well as find help for our non-contracted providers. You can see if it's in process, in pending, sort of limited number of statuses, but there are sort of different ways that you can sort of receive feedback when it comes to CS.
Just add on the ECM side, if you submit us a referral form, we'll send you back a letter that says what the outcome of the referral was, and confirm that they've received the authorization, or in a very rare case that they weren't qualified. So that's closing the loop.
Great, thank you. We do have a question around respite care. If we can just, let me ask this question real quick. It says, currently regional centers provide respite care, including personal care to IHSS recipients who are qualified for regional center services. If ECM is also going to provide respite services and personal care, will there be any possibility of duplicate services?
Well, one thing to clarify
Yeah.
real quick is that ECM won't provide the respite care, the personal care. They'll plug into community supports that are you have to qualify for separately. But go ahead, Katie.
I'll tell you, we talked to the regional centers when we were trying to bring on providers. We were really hoping that potentially we might be able, to have them also be contracted as providers. I think because we knew that they were providing personal care and homemaker services and respite. And even some of our providers work with our regional centers. So, my understanding, and Janet may be able to help me here, is that, Medicaid is the payer of last resort. And so, if they're utilizing these services, they would not be able to utilize our services at the same time, because I think that those are also state funded, but they would be able to utilize personal care and homemaker services and respite at a later time if they were still qualified, but probably not simultaneously.
Yeah, and I think, Katie, you're right. And that's where the care coordination and the conversations between the entities really comes into play. It's really having that conversation of, hey, we've got this member. What are you guys doing? What can we do?
Exactly.
Because we definitely don't want to duplicate services. Yeah.
Yeah, and I think personal care is personal care and homemaker services is really supposed to be a stopgap, right, in between to prevent any sort of gaps in services. So it can be longer term, but I think we're sort of all in this together, and the hope is that while the plans are learning how to work differently, I think providers are learning how to work differently, both internally and then also just interdisciplinary and across providers and county departments, and work in new and different ways. So.
Great, thank you.
Yeah.
All right. Oh, did I go on? I went on. Eric, do you want to go on?
Yeah, sure. Sorry, I was on mute here. There's a couple more complementary programs that I'll touch very lightly, and I know we're running short on time. But community health workers, these are folks who have sort of have a cultural competency, language competency. They can kind of help our members navigate the healthcare system, where they've had access issues. They can help with that access, just through that competency. They provide education services. They provide health education. They can help navigate the system. They can do certain kinds of screening and assessment, support asthma prevention, and just generally support the member, with what their needs are, and advocate for the members. So that's our community health worker benefit. Very excited about that. Certainly complements our ECM and community support services. Although there is a risk of duplication there, but that's avoidable. And then doula services, this provides visits both prenatal and postpartum. There's an extended visit, post a 3-hour visit that's paid for postpartum, which I think is pretty neat. And they support the mother during labor and delivery. They provide general guidance and help the parents navigate, and they help to create a birth plan. They can also link to community resources. So, pretty neat complimentary service. Right, that's it for that, in case there's any questions. And then this is just, if we're interested in how, social service departments or counties in general can become ECM providers. I did provide some information here. That process starts with a letter of interest, and then there's a certification process to make sure that a provider has the expertise in a particular population to focus to serve those members in the way that they should. And then there's a contracting process. So I'll leave it there, but happy to come back to that if anyone is interested in knowing more about that. Next slide, please. I'm not going to dwell on this either, but I think I mentioned earlier that the ECM is paid at a per member per month rate. We call that a case rate, and that requires at least one interaction with the member in the month, and that's a minimum, right? That's a minimum to be paid, but is not necessarily the minimum expectation when it comes to the services that a member needs, right? It really depends on the member's needs in that particular moment. It's not, we're not that's the expectation. All right, so there are different ways to kind of structure payments for different services. So I just added a couple here for reference. Our community supports use these, fee for service rate and a reimbursement rate. But happy to come back to this if there's any questions about it, if there's anyone interested in becoming a provider. All right, next slide. And just to highlight this, we try to incentivize quality of our providers. We pay an additional 10 or 15% on top of our regular rate to our highest quality providers that we're measuring here through these process metrics. This is our current kind of sort of short list of metrics that we're using, and I wanted to highlight this because we love to be talking about outcome metrics too. We love to be talking about how we can measure quality in a deeper way. And I think that that's something as, we kind of deepen our collaboration with counties and with the, adult aging community, we'd love to have conversations about how we do that. That's it for that slide, I think. And I think that's it. There's a resources slide here and some contacts on the last slide. All right, thank you. That's all I've got.
Great, thanks, Eric. I know there's a question in the chat about MOUs also, so I will stop sharing and I'm going to turn it over to Jared Martin to talk about MOUs execution. Jared, are you out there?
I am, and I'm going to hijack your screen here in just a second.
There you go. It's all yours.
Perfect. Thank you, and hopefully everyone can see it. Confirmation, if I may, please. Is that a nod, Baljeet? Thank you. I appreciate that. Just a quick slide. I'm sure we're going to have more conversation around what I'm about to talk about here in just a moment anyway. But at this point in time, my name is Jared Martin. I'm a program director with Anthem's County Account Management. So I report to Janet Payne. And our team is responsible for working with our county partners on the MOU executions right now. So you're either seeing my face or some of our colleagues on this call, Lolly Watrago, Cleo Macklin, Denise Ornelas, and you're working with them throughout the various stages of the execution process right now. So I know with the recent revisions to the IHSS MOU, we've been thoroughly reviewing that document, probably ad nauseum at this point, going back and forth with the various MCPs at the table and just discussing every little bit of additional language possible that we can, right? So it's an exhaustive process for all parties, I'm sure, but we appreciate your patience on every step of the way. So that's where we're currently at right now. It's just, we're in the state of review. I think all parties, for the most part, are at the table. We're at least talking, we're collaborating, we're reviewing, we're redlining, we're commenting, we're sharing feedback. I did put on here as a near-term consideration is data exchange. And I think this conversation started between Peter and Eric, and then a few other people started chiming in about data elements. It's going to be imperative. Part of the IHSS MOU is Exhibit C, and Exhibit C is the data elements component of the MOU, right? So this is an opportunity for us to to discuss what kind of data is realistic to share, what you can realistically ingest, what you can realistically produce, what we can realistically ingest and produce ourselves, right? How we do it, how we exchange it, how frequently we exchange that. And that's all part of the process of the MOU, right? So we're gonna go forward with everything outlined within the MOU. As we execute it, we'll step into the operationalization process of the MOU, which is figuring out exactly how we get all these pieces to work together, right? We're gonna have joint policies and procedures. We're gonna have these data exchange elements that we're gonna have to work through. There's gonna be a lot of learning together and collaborating together on all the various next steps. So on that note, Kingston, I don't know if I answered your question or not, but I'll stop and pause for questions.
Oh, hey, Jared. This is Kingston from Santa Clara County. Yeah, that answered my question. The only thing is we haven't been reached out yet as a county. Is that something that I would talk to you about starting the MOU process with Santa Clara County?
Kingston, so we'll make sure and absolutely connect with you. Cleo Macklin, I believe, is on this call also.
Okay.
He is the program manager for Santa Clara County, but I will make sure that we connect with you personally.
Great, thank you.
Thank you. Any other questions before I move on? If not,
All right. I think
yeah, really quickly too, Janet, sorry to cut you off.
no, go ahead.
Part of the MOU execution, so I mentioned Exhibit C is the data elements component, but in Exhibits A and B, those are opportunities for us to identify for all parties involved, the responsible persons and the liaison. So those individuals at the county and those individuals at the health plan that you'll be working with consistently. So as we continue to work together, we'll document in the MOUs exactly who it is that you'll be working with throughout the various next steps of the operationalization process of the MOU. So your IHSS liaisons, your LTSS liaisons, and your responsible persons from the MCP plan, and likewise our counterparts at the county as well.
All right. Any other questions on MOUs for Jared? Otherwise, we'll turn it back over to Baljeet.
Great, thank you. Thank you so much. So before we get to the Q&A, I did want to give Renita with CWDA an opportunity to introduce herself. So I'm going to hand it over to you.
Thanks, Baljeet. Hi, everyone. I was a little late in joining the meeting today. So, but just wanted to introduce myself. My name's Renita Polk. I am the Deputy Director of Aging, Disability, and Older Adult Services at CWDA. I'm pretty new. I've only been with CWDA for about 3 months. So some of you on the call may know who I am, but for those that don't, I just wanted to introduce myself. But thanks, Baljeet, for giving me a quick second to introduce myself.
Yeah,
Nice
thank
to
you
meet
and
you.
welcome. So I want to kick off the question and answer. I will start with one question that I have had, and I know that I think I know the answer to this, but I want to make sure everybody does, and that we hear it from Anthem as well. So especially with our IHSS populations, we do know that some of the recipients have a share of cost Medi-Cal. And so how does that impact their access to CalAIM benefits and services and becoming a part of a managed care plan?
Well, I can speak for ECM real quick. I don't believe share of cost members have access to ECM. It's only for full scope Medi-Cal.
That would be the same across for all CalAIM benefits services.
Yeah, okay. That's what I thought and just wanted to confirm that because we do have a number of recipients in the IHSS program that have a share of cost. And as we've mentioned in our CalAIM 101 and 201 trainings for county staff, that there is a like program to ECM, which is the PACE program. And so any of your recipients that do not are not eligible for ECM or any of the other additional benefits under a managed care plan, you might want to look into PACE as an alternative for them. So I do want to open it up to counties, county staff here. If you have,
Baljeet, I'm sorry to interrupt, but I think one more point I think is important to make, especially particularly for this audience, because there's so many, you know, of your folks who are dually eligible. We have special rules around dual eligibles. So anyone who is that is dually eligible for Medi-Cal and Medicare. So for those in fee-for-service Medicare, they have full access to CalAIM service, or they have full access to ECM. Again, I'm going to limit my comments to ECM here because I'm going to get in trouble if I try to get broader than that. But they have full access if they're fee-for-service Medicare. If they're in a D-SNP plan, it depends on what kind of D-SNP plan they're in, but either way, it's going to be the responsibility of the D-SNP plan. They have an ECM, what they call an ECM-like program. It's modeled on the Medi-Cal program, but they are responsible for providing those ECM services. So that's something it's a wrinkle, and then it adds to the the burden and the navigation burden to figure all that out. I thought that's an important point for this audience.
yeah, thank you so much, Eric. So if you do have a question, a comment, please just ask that you raise your hand and we'll monitor that and call upon you. Let's see, is it Khalil?
Yes, this is Khalil Macron. I just wanted to let Kingston know that I did put my information in the chat for he and I to coordinate regarding the IHSS MOU in Santa Clara County. Thank you.
Hey, Khalil, this is Kingston. I got it. And I also got Jared's contact as well. Thank you to you both.
You're welcome, and thank you.
Great, thank you. So the questions, this could also be an opportunity to share your experience or your staff's experience in making referrals for ECM or CS, kind of navigating this landscape with your populations that you serve. So any brave soul out there that would like to ask a question, make a statement, or share how the experience is going in your local county.
I think I'll just add to it's, we're all in it together and we're all learning together. It's just been an interesting adventure as we go along. And so I think, Baljeet, you're absolutely correct. I mean, there's no wrong question, and, we want to hear it. If there's concerns out there, we definitely want to know where we need to improve or what's not working, or, maybe what needs to be done differently. We're definitely open for feedback with regards to that. Quiet group this afternoon.
I have a question. Just out of curiosity, when it comes to finding the providers that help assist like our clientele, how do you locate your providers? Because we have a very difficult time locating providers for IHSS alone. So how do you go about identifying those that help ours, as for the community support and such?
Start, Katie, and then if you want to chime in here, or Eric as well. So, early on, we started by identifying stakeholders locally within each county. Often the county departments would let us know, because although we're virtually statewide, we reside wherever we reside, right? And so making connections with, with county stakeholders, and then them letting us know, hey, have you reached out to so-and-so or this organization? So we, built a mapping of every county, and then just went out there and started building those relationships, and that, you know, sort of word of mouth just spread, and being able then to identify those really local organizations, specifically for personal care and homemaker services. Though I know, as Katie mentioned before, we've had a little bit of a hard time, to be honest, in identifying a, you know, a substantial network in that area for us too. That has been, you know, a challenge. And also, as Katie mentioned earlier, we do have an organization that we are contracted with to support that service statewide for us. However, they are they will help to identify or work with the caregiver in identifying as someone for respite services, or, you know, personal care homemaker services as well. So they're kind of, you know, they're available, they have the training, the support ready to go, but they'll work with the client in identifying, okay, is there a family member that you know, you'd like to step in here? So we're also open to ideas, but that's a couple of our ways. I don't know if Katie, you have anything to add.
Yeah, I mean, I think to the comment that, you know, we're all learning together. I think it's really important to share and emphasize that DHCS is learning too, and making changes and edits, and I think reflecting a certain level of flexibility that I think early on many of us weren't so sure about. And now we're seeing, you know, them very responsive to our suggestions, to provider suggestions. And I will let you know that coming down the pike is some more updates to community supports. They are going to do, hopefully in the fall, it's supposed to be the summer, but I think in the fall, some more updates to the community supports policy guide. And I do think it's going to include some updates to personal care and homemaker services, because there is some guidance in there that has made it very challenging for us to partner with and find providers that can fulfill the criteria that's outlined. So we have you know, leveraged many of the partners on this call with our county departments to find those providers. And like I said, connecting with the regional centers and our home health agencies and, you know, hospitals and, you know, CCS and all these different, you know, pieces of care along a member's journey. So to be able to identify the providers that we've contracted with. So we look forward to those changes, and we look forward to, you know, people continuing to learn and our providers seeing that potentially they could be, you know, a part of CalAIM.
Thank you.
Great, thank you. Anyone else? Question, comment, what is happening? What are you hearing, seeing at the local level with, you know, referring to CalAIM services? What are you hearing back from staff about it?
A question, if for the group, particularly for our IHSS team that's on here. Personal care homemaker services, I mentioned earlier, our, you know, member eligibility requirements is that members on the wait list for IHSS, or they're at the other end and they've maxed out on their IHSS hours. Often, you know, our team who are creating the authorizations for those services, they'll connect with a member to, you know, and have a conversation about, you know, where are you at with IHSS? Did you just sign up? Are you on the wait list? Kind of get an idea. But we're looking for, is there another way for us to identify, you know, here's Selena, here Anthem, Katie and team, here are your list of members every month that are, you know, receiving IHSS. And maybe this comes with the MOU, right? Once we have something a little bit more formalized in place, but a way to do that, because right now, you know, we do have some information, if we've received it from either IHSS in the past or a variety of different places that's in one of our systems. Otherwise, we're having a conversation with a member. And so my question is, you know, what is there an alternative way? I don't know if that varies by county, or, you know, a way for us to exchange that information, the member information.
So I can speak to this a little bit, and then maybe I'll ask a county person to add to it. But it's our understanding, and we've asked this question a couple of times, but it's our understanding that DHCS is providing the managed care plans with information, which could be aid codes and maybe some other information, but we don't know what that other information is, that clearly identifies IHSS members, IHSS recipients.
Unfortunately, that's not true. Yeah, we can talk about that more, but we do not get IHSS data with a couple of exceptions that are sort of legacy from earlier programs like CCI. We do not receive IHSS data. That would be very helpful to have.
Okay, so that's good to know, because we were under the understanding, like I just mentioned, that you were getting IHSS aid codes of some kind or additional information. So that's good for us to know. I think this is one of the areas that the counties are still trying to navigate and figure out based on the MOU in regards to what data are they allowed to share and how could they share it. There is the release of information route that a lot of counties are really looking at, which would require the member to sign, you know, that release in order to be able to share that information. And then how do you share that information? Because the counties are using a database system that may not give you it in a format that you would be able to then easily decipher and use. So some additional challenges there around sharing data. And if there's anyone at the county level that wants to add to that, please do.
State does have a format for IHSS data that was sent to us under CCI that seems quite helpful. It has, you know, it's basically just you know, it's a simple, you know, flat spreadsheet that has, you know, the number of hours, some information about the assessment, the member's assessment, what, you know, what went into determining those hours. And, you know, we've been working with the limited data that we have to figure out, well, what does that say? What is that? How predictive is that of the risk of institutionalization? We went through that process early in 2022 when we were trying to develop our algorithms, but unfortunately we don't have that data, you know, in a consistent basis, and we don't have it across the state, so we weren't really able to use it. But that we do have a model for it. It comes from the state. It comes through CMIPS.
It might, if you don't mind, if you could share that with us, and you can definitely send it to myself and Andrea so that we can kind of look through that. And see if that would be, you know, counties would be open to that.
Yeah, I could probably send a de-identified version. I'll have to dig that up, and I can send you the, you know, spreadsheet.
Great, thank you. Anyone from the county want to add to what I just stated about the data sharing complexities?
It seems to me, one thing, you know, I'm really excited about data sharing. I mean, I think that has a lot of promise. I think another thing, just through assessment, you know, your IHSS assessment process. I mean, you're seeing that risk, you know, doing that assessment, and that seems like an opportunity. I mean, I'd love to get your feedback on whether you think it's an opportunity to maybe make some referrals. You know, perhaps the IHSS and ECM are complementary, again, not duplicative. So while you're assessing members for IHSS hours, could you also be, you know, looking out for the criteria for, do they meet the population of focus criteria for at risk of institutionalization?
Yeah, there are many great opportunities for us to partner and better understand, the how to best support your work as you best support county's work. We're partners in this process. So, yeah. All right. I don't see anyone else raising their hand or anything. As much as I say I'm comfortable with silence, I'm actually not that comfortable with silence. So we do have a survey for our participants, our county participants on the call today, and this is just to kind of continue to give CWDA, CFPIC guidance on what you at the county level need as you continue to engage in CalAIM and all the benefits and services and partnering with the managed care plans. We want to continue to support that work. Really appreciate all of you being here this afternoon. Thank you so much for joining us.